Uh, I'm Neil. And let's see where, the slides are there already. So I picked out three hot topics from the conference, which I thought would be of interest to us. Digital mental health care. The reason for that is that it's using digital care, we can reach a lot of people with very few hours of our time. And one of the things that we're short of is time, and we have a lot of patients. There's a website which has quite a lot of information on this, but I'll take you through some of the digital interventions. Then tech addiction is probably one of the biggest problems we see in teenagers, but not only teenagers. I won't say who it is, but there's somebody who works for me. Every time I'm in a meeting with her, she's looking at Instagram and I don't know what else. I have to keep saying to her, do you know who I am? Put away your phone. She doesn't get it. And then recreational drug abuse. One of the things that I've noticed is many Kenyans send their kids to universities in other countries, for better or for worse. And sometimes they come back in a worse condition. And that's when I meet them at Jerome Hospital. So I think it's good for us to know what's going on in the rest of the world. It's a subject we don't really like to talk about. But before I go into that, I just want to say a few words about the Royal College and the African division. And we've got people from other countries in Africa. So I just wanted to know how international our audience is. I recognize some brothers from South Africa, even though we haven't said hello, and I really want to say hello properly at the end of this morning. But how many South Africans are here? 1, 2, 3, 4, 5. Welcome, ladies. Is there anybody in this meeting from Uganda? I know there was somebody yesterday who I didn't get to meet. Not right now. And from Tanzania? There were two. The reason I'm interested is that the college has suddenly woken up. Not suddenly, let me be fair. Over the last few years, they've been waking up to the fact that 20% of their members are outside of England and that they have a role to play to reaching out to all of the people who've trained in England and have moved out of the country or moved back to where they came from. People like me, and like my friend Arthur, who's here, who's Kenyan but working in England. They've also realized that they have kind of social responsibility role. So they're very interested in Africa and supporting the work that we do in Africa with their massive resources. The NHS psychiatrists complain bitterly about having too many patients and too much work. But they have, maybe probably 1/10 of the number of patients that the average Kenyan psychiatrist sees, and many more resources. So it's an interesting story about how they might be able to use some of that resource, like technology. So let me come back to the hot topics. Digital therapy for anxiety. NICE is the UK national, what's it? National Institute for something, clinical excellence. Is that right? Those who know. Professor? Any case, they write guidelines which are evidence-based. In other words, people have done research on this, it's shown to be safe, and it works. And there's something called Luminova, which is a program, which is essentially a game. It's a role-playing game where people go into space and they do things. And it's particularly helpful for agoraphobia and for social. There's another one for social anxiety, and they also have something that they call online support. All of these things have gathered a lot of momentum during COVID, where lots of things had to move online. And one of the reasons that children and adolescents don't go to psychiatrists or psychologists or to any form of therapy is they're supposed to be in school. Now their parents have to give up time from their job, take them to the doctor or the therapist. So everything, I think, working with children is going to be moving much more online. So I think these things might be worth finding out more about. Then digital therapy for psychosis. They've extended the same idea to people with schizophrenia or schizophrenia symptoms who don't go out. So those are the people we don't see. They stay at home with their families. They're so paranoid that they don't go out of their house. Or if they do, it's not for long. And they particularly, I'm sure, don't like going to see doctors because they would justifiably be afraid that they might be admitted. So again, they've used this. I think they have an advantage there because they do a lot of home visits. So they go and visit these people and introduce them to this type of digital therapy. Another therapy which has been very successful is treatment of tic disorder using something called Orbit. So tic disorder is a difficult disorder to treat. The neurologists don't want to have anything to do with it. So they often come to psychiatry. Something just to keep in mind. The other thing that's evolving is diagnostic tests. It's very difficult to go online and then not be asked, do you want to do a questionnaire to see if you have depression or ADHD or bipolar disorders, I think the most popular one. But what they've done is they've now developed quite a sophisticated test that you could do in your own consulting room for somebody where you want to verify a diagnosis of ADHD. ADHD has become a very popular diagnosis with, I think, half the students in one university that I know of are taking some sort of stimulant. But more than half of those don't have ADHD. But they'll still come to my office and say, please, can you just prescribe me some Ritalin for exams? Which is not really the way that we want to go. And this gives us some kind of a concrete way of saying, wow, you do very well on this test. You obviously don't have ADHD. Because what often happens with ADHD is one parent's in favor of them being medicated and the other one is not. So how do you resolve that argument? Low and middle income countries. So this is a study that's been going on for a long time. The first papers came out in 2008. This is the Thinking Healthy program, which is a program which is free from the World Health Organization. And I think many of these things will become free. I imagine that it's been implemented in Kenya. Does anybody know about this? It's been used with treating postnatal depression. Those who are involved in the MH-GAP studies might have come across it. In any case, it's something that we could rapidly and effectively introduce for treatment, screening and treatment of postnatal depression. And first, they showed that it would work if community health workers were trained with it, and more recently, peers. So you don't need to take the community health worker and give them an extra job. You can train someone in that community who's a peer to do this work with postnatal depression using this digital tool. Then, behavioral and tech addiction. I don't know what the prevalence of all of these things are. That wasn't pointed at all. But there's a lot of things that you'll probably see as you read down that list: internet gaming, internet gambling, cybersex, infobesity. That's when people spend hours and hours and hours just cruising around the internet looking for information and fun facts. Being on social media, texting and emailing, online shopping, very common in younger people, but increasingly common in older people. I was looking around the other day, not now, to see how many people were on their phones while a very interesting talk was happening, and it was a lot of people. So tech addiction is any obsessive tech-related behavior, but there are benefits. And when you tell your kids, come away, stop playing PlayStation or whatever it is, they always complain and they're unhappy about it. That doesn't mean that they're addicted, because there are also some benefits. So they improve their multitasking ability, believe it or not. They improve their eye-hand coordination and their visual tracking and ability to imagine things in space actually improves as they play games. But there's a limit. So if you do that for an hour a day, you'll get those benefits. But if you do it for 8 hours a day, you don't get better and better and better. But there's a number of parents who come to me. They say, I booked an appointment for my child, but they didn't come. But I've come to tell you they spend all day gaming. And what do I do? It's a tricky one. The negatives for tech addiction are people's academics suffer. They don't exercise, which young people, and increasingly important as you get older, need to do. Their sleep is disrupted because they come back from school at 6 o'clock, they start playing. If you don't check on what they're doing, at 2 o'clock in the morning, they're still on that game. They lose out on friends. Their friends are online, so they don't have what I call real face-to-face friendships. And they become lonely, and they end up losing their self-respect and lose their ability to engage. But what was quite interesting is gaming doesn't seem to increase the risk of being violent. A lot of parents will say, my child is violent because he games and he watches people kill each other on that game. But the evidence is saying that that isn't so. So there are treatments now for tech addiction. The main one is CBT type treatments, but using tech as a tool, because people won't engage in anything that's not tech if they're of a certain age and that's their thing. But if you can engage them in a treatment to treat their tech addiction, it's possible using CBT. Medical treatment, the subtype of those who get aroused and have impulse disorders, they seem to benefit from opiates, but it's off-label use. Opiate antagonists, sorry. And then the obsessive subtype can benefit from SSRIs, again off-label, so you have to be a little bit careful about the information that you give and monitoring for side effects. Very quickly on to substance abuse. I'd hoped to give a whole talk on cannabis and psilocybin because that's a very interesting topic. Didn't really come up much at the conference, but I hope I'll be invited to do that in one of our Jerome Hospital EPD lectures. Cannabis, what's very clear now is that the more you take, the more risk of psychosis there is, short-term and long-term. So 16-year-olds who are smoking every day, their risk is definitely increased for schizophrenia and for psychotic disorders. But we're also finding out there are many medical applications for cannabis, treatment of cancer, treatment of pain, even the treatment of anxiety, although it's not licensed for that. Opioids are now available online. You can go online and purchase them. They get sent in the post from countries around the world. So if you're an opiate addict, you don't have to find a dealer. You just go online and do it, which is causing massive problems. I think it's not such a big deal in this country because, for better or worse, things get inspected when they arrive in the post. The other problem is that other drugs, what I call ordinary recreational drugs or party drugs, are being mixed with opioids. So something like MDMA is used very often as a party drug. Now the clever dealers are mixing it with opioids so that although you don't get addicted to MDMA, you can very easily get addicted to an opioid that's in it, and then you think you're addicted to the MDMA because you get cravings. Ketamine, many of us are using in our clinics now to treat depression, but it's also available on the street. People snort it to get a high, a very intense high, and hallucinate. And they go into a space they call the K hole. So if people are talking about a K, a lot of you might be thinking, what is that? It's ketamine. Ketamine can also be associated with awful side effects, especially in recreational doses, much higher than we'd use in our clinics. Ketamine cramps and ulcerative cystitis. So if your ketamine addict is complaining of blood in the urine, that's why. GBH, another party drug. I don't hear of it much, but I had a young lady come from London. She's from Somalia. and she was withdrawing from GBH. It was one of the most difficult things to manage. And at the time that I admitted her, I didn't know that they were life-threatening withdrawals. So I was lucky. We should have admitted her to a place which had ICU facilities, because these folks have seizures and can die. So when you take the drug history from someone who's coming, especially from overseas, ask them about GBH. It's very addictive. It's a clear liquid, looks just like water. So the kids walk around with it saying, I'm drinking my water, but they're actually drugging at the same time. Other things that people get up to, maybe in this country, but especially in the UK, it seems to be popular, is chemsex. In other words, using recreational drugs to enhance their sexual experience. And I'm talking about things like Viagra. So methamphetamine is used as an adjunctive drug to give people more sexual highs. They smoke it, and they also inject it rectally, because everyone knows smoking's bad for you now. So they're finding other ways to do it. Nitrous oxide is something that is offered in balloons. So if you go to a children's party and there are lots of balloons, you want to know what's been used to blow them up. So it's something that's now popular in the sort of 12 to 18-year-old nightclubs. They have those, and there are lots of balloons. And because you'll never detect or do a blood test for nitrous oxide, it's a very convenient drug to play around with. But it can cause a critical vitamin B12 deficiency. So sometimes these children present with neurological symptoms. So the warning is that the UK universities don't criminalize drugs. They don't throw you out if you've been drugging. They accept it as part of what's going on, and that they engage with it using what they call a harm minimization strategy. So that they feel it's more risky to chase after people who are drugging on their campuses than to just accept it and welcome them and say, you need treatment. So beware. That's it. That's the end of my presentation. Thank you.